Objectives: 1. Understand the difference between non-ionizing and ionizing radiation. 2. Understand the difference between stochastic and non-stochastic effects. 3. Be able to discuss the concept of ALRA. Everyone is concerned about patient radiation dose. From 1993 through 2008, radiation dose attributed to medical radiation rose from 0.54 msv to 3 msv per capita. The largest component of the medical patient radiation dose W is CT scanning, 49%. This is despite the fact that CT scanning makes up only 17% of the total medical procedures that contributes to a patient's radiation dose. Radiation dose for all diagnostic exams should be minimized to the lowest amount of radiation needed to produce a diagnostic quality exam. What is radiation? Radiation is emitted from unstable atoms. Unstable atoms are said to be radioactive because they release energy, radiation. The radiation emitted may be electromagnetic energy, X-rays and gamma rays, or particles such as alpha or beta particles. Radiation can also be produced by high-voltage devices, such as X-ray machines. X-rays are a form of electromagnetic energy with a wavelength that places it into an ionizing radiation category. In a diagnostic exam, these photons can penetrate the body and are recorded on digital or film medium to produce an image of various densities that show details inside the body. There is no threshold for stochastic effects, so any imaging procedure or therapy that involves the use of radiation involves some risk. When performed properly, the risk is usually very small and is far outweighed by the medical benefit of having the procedure. Regardless, the concept of ALARA, keeping the radiation dose as low as reasonably achievable, should always be employed to minimize the risk. A small percentage of imaging and therapy studies performed in the hospital can potentially exceed threshold values for non-stochastic effects. Radiation therapy and interventional fluoroscopy procedures may result in radiation doses that exceed the threshold dose for skin injuries, and less frequently for cataract induction. The procedures performed in these areas are often life-saving, and every effort to minimize the magnitude of these effects is taken. Resources: as you continue your career in medicine, you will specialize. Part of medicine, in virtually all areas of specialization, involves ordering X-rays or nuclear procedures for your patients. In the news media, great attention has been paid to the increase in medical radiation dose to members of the public. Currently, there are discussions and debates over the appropriateness of ordering certain exams without need. This will become a health system financial restraint as well as a public health question. Objectives: 1. Identify the 4 naturally occurring densities visible on a conventional radiograph in order from the highest to lowest density. 2. Define and give 2 examples of the silhouette sign on a frontal chest radiograph. Radiographic densities: let us disregard the anatomy seen on the radiograph for now and concentrate on basic radiographic principles. In Fig 2.1, you can see examples of the 4 basic densities: bone, soft tissue, fat, and air, which are visible on a conventional radiograph. Main radiographic densities. 1. Bone. This is the most dense of the 4 basic densities and appears white, or radiodense as radiologists prefer to say. 2. Soft tissue. All fluids and soft tissues have the same density on a conventional radiograph. This density is slightly less than the bone but slightly greater than fat. One advantage of CT scanning is that various soft tissues and fluids can be discriminated as different radiographic densities to a much greater degree than conventional radiographs. 3. Fat. This density may seem the least obvious to you. Fat can be seen interposed between various soft tissue and fluid densities. Abdominal fat allows us to see the edges of various soft tissue structures since the fat is slightly less dense than the organs themselves. For air, the lungs, bowel gas and the air surrounding the patient are examples of air densities. Air densities are generally quite dark, almost black, on the radiograph. Thus, the lungs are not radiodense but are instead said to be radiolucent. Why does the air in the lungs appear less black, more radiodense, than the air around the patient? This is because the air density in the lungs is added to the densities of the superimposed chest wall structures. There is an additional density on some radiographs which may be more dense than bone, metal density. This is not included in the above classification because it is not a naturally occurring density. Examples of metallic density on the radiograph include orthopedic hardware, the wire sutures in the sternum in the patients who have undergone cardiac surgery, and the wire leads seen in a pacemaker. Radiographic densities are normally additive in an arithmetic way. This means that a soft tissue density which is twice as thick as an adjacent soft tissue structure will be twice as white. Conversely, a structure which is half as dense as an adjacent structure but twice as thick will demonstrate an identical radiographic density. The silhouette sign. What is the effect of juxtaposition of structures of varying density upon each other? When two structures of different densities are adjacent, i.e., abutting each other, the interface between them will be clearly delineated on the radiograph. For example, the soft tissue density of the heart is clearly delineated from the air density of the lung along the cardiac border. However, when two structures of the same density are adjacent or overlapping, their margins cannot be distinguished. For example, when pneumonia fills the alveoli of the right lung with fluid, the lung becomes fluid density. The normal interface between the right heart border, soft tissue density, and the lung, air, may become invisible. The right heart border can no longer be seen. This is called the silhouette sign and is one of the most useful principles in radiology. Other examples of the silhouette sign include the following. 1. The heart cannot be distinguished separately from the blood within the cardiac chambers because both have soft tissue/fluid density. 2. The dome of the liver and the inferior aspect of the right hemidiaphragm cannot be distinguished radiographically since both have soft tissue density. You would only see the dome of the liver and the right hemidiaphragm separately when free intraperitoneal air is present. This is because the air density is interposed between the two soft tissue densities. The silhouette sign will be used repeatedly in all sections of this course and in interpreting radiographs clinically. It is very important that you have a clear understanding of this principle. Conventional radiology. Objectives. 1. State the convention for describing standard radiographic projections. 2. Explain why cardiac size differs on AP versus PA radiographs. 3. Define the lordotic projection view and 2 indications for its use. 4. Discuss how the following variables and techniques may alter the appearance of a conventional chest radiograph: underexposure, rotation, inspiration, and expiration. The main purpose of this chapter is to demonstrate the effect of various technical factors on the appearance of conventional radiographs. The radiograph projection. The radiographic projection is named according to the direction in which the X-ray beam passes through the body of the patient when the radiograph is taken. In other words, if the X-ray detector was placed behind the patient and the X-ray tube was placed in front of the patient, the X-rays would pass from the front of the patient through the back of the patient onto the X-ray detector in an antero-posterior AP radiograph. In a posterior-anterior PA radiograph, the detector is located along the anterior aspect of the patient's body with the X-ray tube posterior to the patient. In this situation, the X-ray beam passes through the patient from posterior to anterior. Note the difference in the size of the heart shadow between the AP and PA radiograph in Fig 3.1. Because X-rays diverge from a point source, objects that are situated farther from the detector will cast a larger shadow. Since the heart is an anterior structure, it is magnified more on the AP radiograph because the anterior structures are farther from the radiographic detector. Demonstrate this principle for yourself by shining a flashlight on your hand so that it casts a shadow on the wall. The farther your hand is from the wall, which in this case acts like the X-ray detector, the more magnified and fuzzy the shadow becomes. Next, look at Fig 3.2. This is the lordotic projection. With this projection, the X-ray source is angled toward the head and the clavicles project superior to the lung apex on the radiograph. This view is used to detect possible apical abnormalities such as tuberculosis or a lung tumor in the apex, called a Pancoast tumor. CT scans are now more commonly used because of increased sensitivity and specificity relative to the apical lordotic chest X-ray. Look at Fig 3.3. The heads of the clavicles and the spinous processes have been marked on the diagram. Since the clavicular heads are anterior structures and the spinous processes are quite posterior, they will move in opposite directions on the radiographs relative to a central axis of rotation. Using this principle of rotations, acquiring two radiographs, one in straight PA and one in slight rotation, may help to determine the position of an abnormality in the lung. Finally, note Fig 3.4. The two radiographs were obtained within minutes of each other. Although this is an extreme example, it is important to realize that radiographs exposed at less than full inspiration produce artifactual crowding of the pulmonary vasculature which can simulate pulmonary edema. In some situations, expiratory radiographs are intentionally obtained. The most common situation is when looking for a small pneumothorax. In this situation, the pneumothorax will become slightly larger relative to the lung as air is expired. Next, examine Fig 3.5. Can you find examples of the four basic densities? Can you find examples of summation of radiographic densities due to superimposition of structures? Superimposed kidneys and stool-filled colon will be more dense than each structure by itself. Examples of the silhouette sign. Kidneys adjacent to liver or spleen will silhouette and obscure each other margins. And last, but certainly not the least, Fig 3.6 is an image from a normal air contrast barium enema. This demonstrates how certain substances such as barium can be used to make certain anatomic structures more visible on the radiograph, in this case, barium and air in the large bowel. Ultrasound. Objectives: 1. State the function of the transducer used in ultrasonography. 2. Define the term sonolucent. 3. Give examples of structures that transmit sound well and that transmit sound poorly. Ultrasound uses no ionizing radiation, and it can image directly in any body plane. In practice, an ultrasonographer, either an ultrasound technologist called a sonographer or a physician, places gel on the patient's skin and moves a transducer across the surface of the patient's body. The gel forms an acoustic seal between the transducer and the skin for better transmission of sound, which results in better images. The transducer can both send out and receive high-frequency sound waves, which transmit through, or reflect off, structures in the body. The returning sound waves are categorized by their intensity, referred to as echogenicity, and duration of time that it takes for them to return. It is the time that it takes for the echo to return from its encounter with an acoustic interface, a structure within the body which reflects sound, that allows its location within the image to be assigned. Fig 4.1. The intensity of the returning echo, echogenicity, of tissues varies greatly. Some tissues, like abdominal fat, are higher in echogenicity than other soft tissues. On the ultrasound image, such structures will appear whiter and are described as being increased in echo texture or hyperechoic. Tissues interfaces that return echoes of lower intensity are displayed as darker on ultrasound images and are described as decreased in echo texture or hypochoy. By evaluating the echo texture of tissues, we can distinguish one organ from another and look for pathologic processes. Fluid-filled structures, such as the gallbladder or urinary bladder, have few or no internal acoustic interfaces and hence appear clear black or sonolucent on ultrasound. Look at the simple cyst found when scanning the breast of a patient in Fig 4.2. Note that the cyst depicted in this image is anechoic, having no internal echoes. Sound waves traveling through the fluid-filled cyst lose less energy, since they encounter fewer acoustic interfaces. For this reason, they can pass through with more intensity when they reach the far wall of the cyst. This phenomenon is referred to as acoustic enhancement, AROS. Some structures that are very dense, such as calcified structures or bone, will prevent sound waves from passing beyond them. As a result, there is no imaging information that can be obtained deep to those structures. A dark band-like shadow is produced beyond the echo-dense structure. This dark shadow can be quite prominent, helping identify even very small calcifications, such as kidney stones. Orientation of the plane of section on an ultrasound image is indicated by the sonographer, who annotates the plane of section on images, either with text or with an indicator image. Scans are normally viewed in real time. This means that structures can be seen to move in the image, example cardiac valves, and structures can pass into and out of the field of view. The images that the ultrasonographer records are only selected frozen images from an extensive examination. In some situations, it may be advantageous to record the examination in real time, known as a video or cineclip. Ultrasound weakens or attenuates rapidly by the inverse square law with distance from the transducer, therefore, structures closer to the transducer are better visualized. Many transducers have been adapted to get them close to the imaged structures. Transducers are included on endoscopes, allowing assessment of the duodenum, common bile duct, and pancreas. An endovaginal transducer provides very detailed imaging of the uterus and ovaries. Endorectal transducers allow high-resolution imaging of the prostate and rectum. By placing the transducer closer to the imaged object, you can also use higher wavelengths of ultrasound, improving detail. Fig 4.3. Color and power Doppler imaging in ultrasound. When an ultrasound beam encounters a moving structure, a change in the pitch or frequency of the returning echo, compared to the echo sent out by the transducer, occurs. This is called the Doppler shift, and it is encountered in real life when you hear a siren from a police car as it drives past you. the pitch or frequency of the sound you hear changes as the vehicle passes. By using information generated by this Doppler shift, images can be generated, giving information about the speed and direction of the moving structure. This is most commonly used in evaluating blood vessels and blood flow. In conventional color Doppler, the displayed color identifies the direction of flow as well as the speed of flow. Power Doppler, which measures the concentration of moving structures, is more sensitive to low flow states, but does not allow an evaluation of direction or speed. Calculating the velocity of moving red blood cells numerically can allow an estimation of the diameter of the vessel in which the cells are flowing. This is the basis of arterial spectral, duplex, assessment of vessels such as the carotids. A spectral Doppler study will display grayscale images, color images, and waveform images of the vessel being evaluated. As the vessel lumen narrows, generally the velocity of red cells moving through it increases. By using multiple calculations along the path of the vessel, multiple velocity measurements and ratios of velocities can be calculated, allowing one to diagnose, quantify, and monitor focal areas of vascular narrowing. Color power Doppler and spectral imaging are used to assess for possible clot in veins, to evaluate areas of arterial narrowing stenosis, and to determine if masses and organs have increased blood flow. You might see increased blood flow in a malignant tumor or reduced blood flow in a torsed testicle or ovary. Doppler imaging is also used to diagnose vascular malformations and assess for the presence of varicose veins. Indications for ultrasound use. Ultrasound is most efficient in thinner individuals or when evaluating structures closer to the transducer. It does not require the use of ionizing radiation, but still should be used cautiously. Studies have shown that prolonged exposure to ultrasound can increase the temperature of tissue and that cavitation can occur when sound waves pass through a structure containing a gas bubble or air pocket, such as bowel and lung. Like any other imaging modality, ultrasound should be used judiciously, only when necessary, and by someone appropriately trained in the field. Ultrasound is most commonly used to image specific organs such as the liver, gallbladder, kidneys, spleen, uterus adnexa, and scrotum. Despite knowing the limitations of ultrasound when evaluating air and fecal-filled bowel loops, and structures around them, ultrasound is being used increasingly to evaluate diseased bowel, which tends to be thicker and often fluid-filled. With appropriate training, point-of-care ultrasound can aid in the detection of pneumothorax, pleural effusions, or peritoneal fluid and in guiding the placement of central lines. Pixels and voxels. If you look closely at the CT scan, you will realize that the picture is actually made up of thousands of little squares called pixels, picture elements, Fig 5.2. Each pixel represents tissue that is about 1 mm or less on each of two sides and is assigned a grayscale value from 0, black, to 255, white. The grayscale value reflects how much of the X-ray beam that small piece of tissue, represented by the pixel, attenuated or blocked as it was passing through the patient. Darker shades, closer to black, represent structures that attenuate very little of the beam, like gas, while whiter shades represent structures that strongly attenuate the beam, like bone or calcification. The thickness of the slice of a CT study is typically 1 mm or less, creating a three-dimensional volume element or voxel which is shaped like a cube. The word voxel is short for volume pixel, the smallest distinguishable box-shaped part of a three-dimensional image. Pixel intensity represents an average from tissue within the voxel. Although the spatial resolution of the CT scan is less than that of a conventional radiograph, the density resolution is much greater. Earlier models of CT scanners used the step-and-shoot method to acquire images. While lying on a motorized table, the patient was slowly moved into the scanning gantry, and a single slice was obtained while the patient was asked to hold his or her breath. These scanners, though remarkable for their generation, sometimes caused small pathology to be missed as patients would not hold their breath in the same fashion each time. These studies had long acquisition times. Current generation scanners move the patient continuously through the scanning gantry during a single breath hold. The patient is advanced while the X-ray tube continuously rotates, acquiring a data set that is much like a spiral in configuration, thus the name, spiral CT. Current scans are performed much more rapidly than with the old step-and-shoot method. The data can then be reformatted into coronal, sagittal, and oblique planes. Current scanners have the capability of obtaining voxels of data so small that the reformatted images in other planes offer nearly identical resolution. CT values or Hounsfield units, WHO. The amount of the X-ray beam that a particular voxel of tissue attenuates can be represented by a number called the Hounsfield unit, named after Sir Godfrey N. Hounsfield, an electrical engineer who won the Nobel Prize in 1979 for his pioneering work in the development of CT. By looking at the Hounsfield unit value of a structure, you can get an idea of what types of tissue may be present: bone, calcification, water, blood, etc. Also, by looking at changes in the Hounsfield unit value of tissue on images obtained before intravenous contrast compared to after intravenous contrast, you can determine how vascular a structure is. Listed below is a basic guide to WHO values prior to contrast. Table 5.1. Contrast studies. -1000 -100 0 +40 +130 +1000 intravenous contrast as well as oral and sometimes rectal contrast agents may be used in CT scans. The small +C label in the alphanumeric image of each section indicates that intravenous contrast was used. Also, if the aorta, kidneys, or ureter is radiopaque or white, it is a good indication that 4 contrast was used. If the stomach or small or large bowel is radiopaque, oral contrast has been given. Optimizing the visualization of specific structures. Since CT scans are created from digital data, the grayscale display can be manipulated in such a way as to display the same information in various formats. These different formats are called window settings and amount to changing the total number of grayscales displayed and the value at which the grayscale is centered. Such changes determine which type of tissue is best displayed. Commonly used window settings include the soft tissue, mediastinal and abdomen, bone, and lung, pulmonary. In Fig 5.3, you see the same image displayed using different windows. In the mediastinal window, soft tissue structures are discernible from each other. In the pulmonary window, the lung parenchyma is well seen, but the soft tissue structures all look the same. Additional electronic manipulation with F-filters and subtraction will provide more information and perhaps answer the clinical question that the raw images can only infer. The weighting represents the exploitation of specific C properties of hydrogen atoms that are exposed to a magnetic field. T1 weighted images classically demonstrate water as hypointense, dark, and fat as hyperintense, bright, with different soft tissues expressed as a gradient in between. In T2 weighted images, water is represented as hyperintense and fat as hypointense, again with soft tissues in the middle. Many of the more complicated sequences, gradient echo, flare, etc., are based on these basic sequences. Advantages and disadvantages of MRI. With the advent of multi-slice CT scanners, CT scans can be acquired or reformatted in many planes. Therefore, a prior advantage that MRI had, exclusive multi-plane capacity, is nearly gone. However, MRI's clear advantage is that it uses no ionizing radiation. Disadvantages of MRI are that it is generally more costly than CT, is less available, and takes longer to perform. Another disadvantage is the inability to scan patients who have ferromagnetic material such as some shrapnel in them. These metallic fragments can actually move with the magnetic field and cause the patient significant discomfort or damage. Although MRI-compatible pacemakers are in development, generally speaking pacemakers are contraindicated because of their ferromagnetic properties. The MRI can heat the leads and inappropriately trigger the pacemaker. But some metal, based on location, type, or duration in place, may not be a contraindication to an MRI check with a radiologist if you are not sure if a device is MR compatible. Additionally, there are web resources that can ascertain the MR safety of different medical devices. Introduction to Nuclear Medicine. Objectives: 1. Define the nuclear medicine, NM, specialty. 2. Be able to define any key terms: isotope, radiopharmaceutical, gamma rays, gamma probe, gamma camera, planar imaging, etc. 3. Define how the component parts of a radiopharmaceutical and the route of its administration contribute to a diagnostic and therapeutic nuclear medicine. 4. Define unique characteristics of different imaging methods in nuclear medicine. The terms specify C to nuclear medicine, NM, section will be displayed in italics when PHI-RST mentioned, and the same abbreviations will be used from its PHI-RST appearance to subsequent NM chapters. Only essential information is described in this book, but references to more detailed articles will be provided from publicly retrievable sources, including the Internet and medical journals. Basic definitions. Nuclear medicine, NM, is a medical specialty where practitioners are skilled in using radioactive isotopes for the diagnosis and therapy of disease. Isotopes are variants of stable elements that have an identical number of protons, p, which determines the atomic number and element's chemical characteristics, but differ in the number of neutrons, n. Wikipedia contributors 2013 g. The sum of p and n equals the atomic mass. Some isotopes are radioactive, which means that they emit energy from the nucleus in the process of transformation to a more stable form, a process called radioactive decay. Wikipedia contributors 2013 j. Every radioactive isotope decays exponentially with a specified C rate that can be expressed as its half-life, T12, which is the time required for an isotope to decay to half of its starting activity. An example of iodine, I, may be helpful to illustrate the isotope concept. Wikipedia contributors 2013 f. The stable element is 127I, which contains 53P and 74N in its nucleus, thus having an atomic mass of 127. The common radioactive isotopes of iodine used in nuclear medicine are 123I, P53, N70, and 131I, P53, N78. These isotopes can be administered to patients in the simplest of chemical form, such as sodium iodide salt, also called radioactive iodine, radioiodide, or radioiodine. Radiopharmaceutical, RF, is another term for a chemical combination containing an isotope, where it is combined with, or labeled to, more complex molecules, pharmaceuticals, such as antibodies, hormones, or peptides, just to name a few. The pharmaceutical component of the RF would determine its biological distribution in the body, as well as its utility for diagnostic and/or therapeutic applications. Radioisotopes and radiopharmaceuticals. The most commonly used isotope in nuclear medicine is metastable technetium-99, 99 MTC. Its popularity is chiefly based on physical qualities, including the gamma ray emitted in the decay process that carries energy of 140 keV, keV, which is ideally suited for efficient detection by NM imaging equipment. Another useful quality is its T12 of 6H, which is ideal for the majority of diagnostic applications. It also has advantageous chemical qualities which allow for convenient labeling to different pharmaceuticals, resulting in a wide array of RFs. Some of them are listed in Table 7.1. The biodistribution of RFs varies according to the route of administration. One of the oldest RFs is 99 MTC labeled sulfur colloid, which demonstrates how different routes of administration influence biodistribution and diagnostic utilization, Table 7.1. In general, the routes of RF administration include oral, intravenous, subcutaneous, intradermal, inhaled, and instilled into a body cavity or an organ through a catheter or a needle. The use of different isotopes is also based on the type of rays, photons, they emit. These include gamma, beta, and alpha photons. Gamma photons have the physical quality of a longer emission range, meters, and thus they are well suited for imaging. In contrast, alpha and beta photons travel very short distances, millimeters, before their energy is absorbed into tissues, which makes them ideal for unsealed, internal, radiotherapy or radioisotope therapy applications. Detection, imaging, and quantify cation. The principle of gamma photon detection is based on its interaction with certain materials that produce a spark of light, or scintillation, Latin origin, which is converted into an electric pulse. This pulse is recorded as one count. The simplest method for clinical detection and quantify cation of gamma ray emissions is a gamma probe, Fig 7.1a, Wikipedia contributors 2013 d. A smaller version of this instrument is available for the detection of radioactivity intra-operatively by a surgeon, Fig 7.1b. This is useful in a number of circumstances when a focus targeted by a RF needs to be surgically excised, but cannot be readily distinguished from surrounding anatomy on visual inspection. These detectors provide no image, but simply count how many rays were detected per certain time, such as counts per SEC, per min, per 5 minutes, etc. This relative unit, example count min, is directly proportional to the radioactivity in the emitting source. Gamma camera, Wikipedia contributors 2013 c, is essentially an array of probes that line a FL detector and is capable of capturing the distribution of the gamma-emitting RF within the body in a two-dimensional, 2D, image, called a planar image, scintigraphy. Those images can be acquired in a static mode, single image, or a spot image, obtained for either a set time or number of counts, or dynamic mode, sequential frames, same as spot images, but set for a same amount of time each and acquired in uninterrupted succession, as exemplified in gastrointestinal NM chapter, Fig 37.1, 37.2, and 37.3. The static mode can be adapted for the whole body imaging obtained by slowly moving the camera head along the long axis of the body and capturing the image along its path, Fig 7.2. Specific to NM is the concept of emission imaging, whereby imaged gamma rays, photons originating from the nucleus, are emitted from within the body. Some of those rays will be absorbed, attenuated, in the surrounding tissues. The less tissue that stands between the organ of interest and the camera detector, the fewer photons are lost and more of them make it to the detector, creating an informative image. For example, to image the sacrum during bone scanning, the detector would be optimally positioned closest to the patient's back, called posterior view, Fig 7.2. If the image of anterior ribs is desired, the front of the patient would be facing the detector, called anterior view. The posterior view would be less useful in depicting the anterior portion of the ribs, as most of the photons would be attenuated. In conventional radiology, refer to conventional radiology chapter in the introduction section. X-rays, photons originating from de-excitation of electrons, are emitted from the tube that is outside the patient and transmitted through the imaged part of the body. Unlike NM imaging, there is a small difference if the tube is facing the patient's front with the detector at the back or vice versa. The same camera can obtain multiple 2D static images from evenly spaced angles around the body. A computer algorithm can then reconstruct a three-dimensional, 3D, depiction of the RF biodistribution. This is called single photon emission computed tomography (SPECT). Newer cameras combine SPECT with a CT on one gantry, called SPECT CT, which takes both SPECT and CT images. This enables the fusion of the two modalities into one blended image called a fusion image. The positron-emitting isotopes are imaged using another 3D imaging technique, called positron emission tomography, PET, which is routinely combined with a CT on the same gantry, called PET-CT camera and imaging. The newest advance is to combine PET with MRI, but only a few PET-Mister cameras are in practice today. These 3D modalities provide tomographic slices in the standard 3 planes for physiological molecular tests, SPECT or PET, corresponding anatomical, usually CT or MRI, and fused slices. This type of molecular and physiological information displayed on the background of exquisite anatomy has been more recently termed the molecular imaging. A simplified display of the physiological molecular 3D images, SPECT and PET, of the whole body can be achieved by projecting the most intense activity along parallel tracks piercing through the entire 3D stack of slices onto a perpendicular 2D plane. This is similar to the parallel rays of light going through the film of an old movie projector and displaying that image on a screen. Owing to this conceptual similarity, this imaging is called maximum intensity projection, MIP. This projection can be done from any angle. Creating MIP images from evenly spaced angles all around the body, 360 degrees, produces a rotating object as if one is looking at the spinning whole body. This technique was invented by one nuclear medicine physician for display of SPECT information and now is used in most 3D imaging techniques, MRI, CT, ultrasound, particularly PET. Wikipedia Contributors 2013 Description of the imaging, scintigraphic, findings is based on relative intensity as compared to expected normal activity. It can be either increased, often called hot spot, or decreased, termed photopenic. It is customary to describe severity of the scintigraphic findings as showing intensely or severely, moderately, mildly, and slightly increased or decreased radio tracer uptake. Pattern of the finding, S, such as fusiform or linear, focal, or diffuse, is important in the consideration of a likely cause. Location is described using standard anatomical terms. The organs of interest can be evaluated for dynamic handling of the RF by drawing regions of interest and creating curves of radioactivity over time, called time activity curves. Those curves can be qualitatively described or mathematically analyzed. The most common metric is half-time of exponential activity disappearance. The activity of RF deposited in the paired organs, such as kidneys or lungs, according to their functions can be quantified as the percent each side contributes to the total function, which is called differential function. Such analyses are standard in renal scanning and quantitative lung function scintigraphy. See Chap 39, Pulmonary nuclear medicine. Cardiovascular and interventional radiology. Objectives: 1. Understand the concept behind digital subtraction angiography, DSA. 2. Be able to list the types of procedures performed in cardiovascular and interventional radiology, CVIR. In cardiovascular and interventional radiology, CVIR, a combination of needles, wires, catheters, balloons, and stents is used to accomplish many things through small access points in the skin. Digital subtraction angiography, DSA. Arteriograms are used to diagnose the changes in the vasculature associated with disease, most commonly atherosclerosis and vasculitis, or injury, either iatrogenic or traumatic. The femoral artery is a commonly used entry point and is accessed at the level of the femoral head. At this location, its position is relatively superficial, and hemostasis can therefore be achieved with ease because the artery can be compressed against the femoral head once the procedure is completed. Different catheters are used to access the branch arteries requiring imaging. Once the catheter is in the appropriate vessel, iodinated contrast, often called X-ray dye, is injected at a controlled rate and volume either via a power injector or by hand injection. Imaging can be acquired on Phi-LM radiographs, which are processed similarly to routine radiographs, or much more commonly with digital subtraction angiography, DSA. In DSA, images are processed with the help of a computer. The initial image has no contrast and is called the mask. The X-ray images are then obtained in rapid sequence while contrast is injected. The computer then digitally subtracts the mask from the subsequent images, leaving only the contrast, thereby yielding a finely detailed imaging of the vasculature, Fig 8.1. If an area of stenosis or narrowing is identified, it can be treated using percutaneous transluminal angioplasty, PTA, with or without the use of a metallic stent. If blood FLO cessation is required in an area of bleeding, example after trauma, or as preoperative embolization to reduce operative blood loss at subsequent surgery, a catheter can be advanced to the vessel requiring embolization. Various materials can be delivered into the artery to stop FLO. Embolization materials include metallic coils, gelfam, polyvinyl alcohol particles, PVA, which is fixed-size particulate material, alcohol, chemotherapeutic material, autologous clot, biocompatible glue, and other agents. Central venous access. Central venous access can be accomplished in many different ways. There are catheters used for short-term to intermediate-term access such as the peripherally inserted central catheter, PICC, and the non-tunneled central line. Long-term access catheters include tunneled infusion catheters and subcutaneous chest or arm ports. Dialysis access catheters, such as tunneled hemodialysis catheters, are also inserted in interventional radiology. Access can be obtained with either vascular ultrasound, contrast venography, carbon dioxide venography, or by using anatomic landmarks. With the use of real-time imaging, fluoroscopy, placement of the line can be quick, accurate, and safe. Difficult access pathways can be potentially treated with angioplasty, balloon dilation, if necessary as well. More interventional radiology procedures. Gastroenteric access can also be performed entirely percutaneously. The placement of gastrostomy tubes, G-tubes, or gastrojejunostomy tubes, GJ tubes, is accomplished with FL uroscopic guidance in a multiplanar fashion, many X-ray angles. The use of FL uroscopy allows the quick, accurate, and safe placement of gastroenteric tubes. Placement of inferior cava filters can be performed through several access points, most often either the common femoral vein or the internal jugular vein. Careful evaluation of the inferior vena cava prior to filter placement should be performed to evaluate for variant anatomy and ensure proper positioning. Genitourinary procedures are commonly performed in interventional radiology. The types of procedures include percutaneous nephrostomy placement, PCN, nephrostomy tube exchange, access for percutaneous nephrolithotomy, PCNL, placement and exchange of nephroureteral stents, NUS, and ureteral balloon dilation, ureteroplasty. Women's health interventions represent a subset of procedures focusing on gynecologic issues. These procedures include uterine fibroid embolization, ovarian vein embolization for pelvic congestion syndrome, and fallopian tube recanalization. Biliary procedures are commonly performed on patients who are clinically ill as a result of biliary obstruction. Percutaneous drainage with placement of an internal-external drainage catheter can be a precursor to surgical resection of a biliary or pancreatic mass. The biliary system frequently needs to be decompressed on a long-term basis, so biliary tube maintenance is also conducted by interventional radiology. If the patient is not an operative candidate, the interventional radiologist can place metallic stents, similar to those used in the arterial system, into the biliary system. This palliates symptoms and improves quality of life without the need for external drains. These are many types of imaging studies and additional procedures that are performed by interventional radiologists. 1. Abscess drainage, using CT, ultrasound, and/or fluoroscopy. 2. Intraoperative cases, example thoracic and abdominal aortic stent grafts. 3. Non-invasive cardiac and vascular imaging, example cardiac MRI, coronary CT angiography, and duplex ultrasound. 4. Percutaneous oncologic interventions, example transarterial chemoembolization, transarterial 90Y radioembolization, radiofrequency ablation, and cryoablation. 5. Percutaneous biopsies, using CT, ultrasound, and/or fluoroscopy. 6. Minimally invasive venous procedures, example endovenous laser, or radiofrequency ablation, sclerotherapy, and phlebectomy. The scope of interventional radiology is quite extensive and diverse. The various interventional procedures expand the diagnostic and therapeutic armamentarium for the clinical care team.